Thank you so much, sir. We'll now move on to the next academic session. This academic session is on cardio-oncology and radiotherapy. It gives me great pleasure to introduce our chairpersons, Dr. Rakesh Gopal, cardio-oncologist from the Chennai Cardio-Oncology Group at Chennai, and Dr. Ahmed Iqbal, consultant clinical oncologist and cardio-oncologist, teaching hospital Betty Claw at Sri Lanka. I welcome Dr. Iqbal to join Dr. Gopal. I request the chairpersons to please introduce our first speaker.
Good morning, everyone. We'll start the session. Just if there's more cardiologists here, for your sake, I'd like to say that radiation can cause pancreatitis, it can cause pericarditis, it can cause myocarditis, it can cause endocarditis, it can also cause conduction defect, and in the acute phase, it can cause something like mild pericardial effusion and mild LV dysfunction and some VPCs. But the problem is long term. Long term, it can typically cause aortic stenosis, which is difficult to treat with the usual TAVIs, and others are condition blocks, including complete heart block. So let me call upon the first speaker, Dr. Ayan Basu. He's a clinical director, radiation oncology, PLS Hospital, Kolkata, to deliberate on evolution from 3D CRT to IMRT, VMAT to IMPT, long-term cardiac outcomes in breast cancer with helical tomography.
So I'm here. May I start? May I start, sir?
Please go ahead.
Respected chairpersons.
We are all ears for you.
Thank you, sir. Respected chairpersons, learned members of the audience, the organizers, thank you very much for having me. And I have been given a series of 3 recently published papers, including one by Dr. Sapna Nangia, who is already in the audience. And so I would request you to, I'll try to keep this short and sweet, and I will request you to direct all questions on the first author of one of the papers that I'm presenting today, because it's a pleasure to have you in the audience, ma'am, at the very outset. So I'll be discussing briefly about the implications of radiotherapy and the cardiotoxicity. And over the last few decades, with significant improvements in primarily the systemic therapy of breast cancer, the survival rates have become very encouraging, as a result of which the consequential late toxicities remains an area of concern. And I believe it is therefore imperative that we as radiation oncologists try to mitigate the late sequelae particularly, of the radiotherapy directed at the thorax for the breast cancer patients, because most of these patients in fact, are going to survive for a long, long time. So radiotherapy again is pretty robust, and I'm sorry, excuse me, can you load the other presentation? It had the images. Do you have it with you? No? Okay, anyways, so moving on because of shorter. Do you have another one? Yeah. So radiotherapy notoriously has contributed to cardiotoxicity, although radiotherapy delivery in breast cancer patients has been pretty robust and has been practiced for nearly half a century now with standard accelerators that we use nowadays. Initially, there was the era of 3D conformal radiotherapy and forward planned IMRT, and the breast radiotherapy was pretty simple. Usually, it involved a combination of multiple photon beams directed as tangents to cover the entire breast. The regional nodal irradiation was usually done for patients where there were adequate indications for the supraclavicular region, the axillary lymph nodes if there was an indication with external extension for multiple positive lymph nodes, etc. And also tumor bed boost in the era of breast conservation surgery. We found that there was, for certain subset of patients, there was an increased incidence of cardiotoxicity, particularly in patients who had indications for internal mammary nodal irradiation, and therefore every attempt has been made over the last couple of decades to limit the dose that is given to the heart. Now, for the heart, there are different predictive models which have found what are the late consequential cardiotoxicities and how it is related to the radiation dose that has been delivered. And one of the surrogates that we use is the mean dose that has been received by the heart. However, in the era of increasing conformity, particularly with the availability of proton therapy in the modern era, as Madam has recently published, we now are looking at cardiac substructures and whether there are implications in terms of individual substructures from within the heart in terms of limiting the late cardiac toxicity. So the first paper that I'm going to briefly discuss today is a very recent publication published only last month. It talks about the long-term cardiac outcomes. Okay. No, I still don't have the images. Anyways, forget it. I had a sort of image which I am unable to present for whatever reasons. Forget it. Let's go back to the slides, please. Let's carry on. Yeah, thanks. So for the radiation oncologists in the audience, we are obviously aware of the amount of radiation that affects the heart, particularly the left anterior descending artery and the left ventricle when you use tangents for radiotherapy and when you use photons for radiotherapy. But one of the ways of limiting the dose to the heart has been the use of intensity modulated radiotherapy. So increasingly we have different techniques. My friend and colleague Dr. Shuman Mollik and his team, Monidip, I can see here, they have had elegant publications on limiting the dose that is received by the heart for breast cancer adjuvant radiotherapy by using techniques like deep inspiratory breath hold, which sort of pushes the thorax and the chest wall and the breast area away from the heart and limits the dose. That is one of the techniques that has been adopted. There are other ways of doing arc therapy, for instance, helical tomotherapy. So this first paper is basically a paper on helical tomotherapy. The third generation helical tomotherapy is called the Radixact X9, and it is one of the elegant ways of doing intensity modulated arc radiotherapy for breast cancer patients. The authors have basically analyzed the data in a single institution study from 180 odd patients. It was a typical mix for radiotherapy, as we see in our clinics every day. There were patients who had undergone breast conservation surgery and mastectomy. Many of these patients who had indications had received anthracycline or taxane-based chemotherapy, which are also known cardiotoxic agents, and some of them, which were HER2 positive, had received trastuzumab also. The reason I mention these drugs is that they also have implications in terms of late cardiac toxicity, and therefore we need to be even more careful in limiting the radiation dose to these patients. And only anatomically challenging cases were taken up for the purpose of this study. Patients who, either because the disease was involving the internal mammary lymph nodes or was an inner quadrant disease or central quadrant disease with bulky disease, multiple involved lymph nodes in the locoregional area, which mandated that there was a case for internal mammary nodal irradiation. So these are typically challenging cases where it becomes a very difficult job for the radiation oncologist to limit the dose to the heart, and these particular cases, these difficult cases, were taken up for the purpose of this study. The primary endpoint was the correlation of mean heart dose with cardiac toxicity, and 1/3 of the patients were obese, and 1/3 of these patients had significant cardiovascular risk factors. The median follow-up period was 9.1 years, because as we know from the early era, from Sharon Giordano's paper and all of the subsequent papers, that typically the cardiac toxicity as a consequence of thoracic radiotherapy starts to appear in the second decade. So 9 to 10 years is what you would want to look at in terms of the appearance of the cardiac toxicity. Only 4.5% experienced cardiovascular effects. However, the interesting part is that there was no significant correlation between the mean heart dose and the major coronary events. The thing to remember is that this is data from helical tomotherapy, and therefore it is one of the most elegant ways of doing conformal radiotherapy or conformal arc radiotherapy for thoracic cancer patients, and generally is supposed to be one of the best ways of doing intensity modulated radiotherapy, which in general has in the best hands less cardiac dose as opposed to 3D conformal radiotherapy, which was practiced earlier. The 10-year overall survival and the disease-specific survivals were as per international data. So in trying to limit the cardiac dose, there was no compromise in terms of the volumes that was treated, nor in the dose that was treated. So the radiotherapy was still safe and effective in terms of cancer outcomes. The patients that were selected had substantial mean heart dose, because these are the difficult challenging cases taken up specifically for the purpose of this study. Normally we try to limit the mean heart dose to around 5 gray when we are planning radiotherapy for breast cancer patients. Here the mean heart dose was around 7.04 gray. That is why these were the challenging cases which were taken up. Only 1.1% of the patients experienced a major cardiac event at 10 years follow-up. However, no significant correlation was found between the mean heart dose and the major cardiac events. Now, the takeaway point from this study is that the dose constraints that we apply as radiation oncologists while approving a plan or evaluating a plan comes from the 3D era, where 3D radiotherapy was practiced. So basically, this study was conducted with the purpose of evaluating whether those constraints are still valid in the era of intensity modulated radiotherapy. And at least for the purpose of these selected subset of difficult patients, it was found that there was no clear correlation. So perhaps we need to revisit the dose constraints that are using for planning purposes. I also have some experience of having used the radiotherapy, the helical tomotherapy platform. We treated several hundred patients over the last 7 years in my previous hospital. We had a Radixact X9, and we also found that specifically in those cases where there was internal memory chain irradiation and locoregional irradiation, which were difficult cases where limiting the heart dose. And mind you, we did not have any sort of motion management strategy in my previous hospital. So these are all free breathing patients. At least dosimetrically, we were finding a significantly decreased mean heart dose and the significant decrease in the dose to the left anterior descending artery, which has correlation in terms of cardiotoxicity. So our experience also replicates the sort of experience reported in this study. The second study that I'm about to discuss is one published again recently in May this year. This talks about whether the mean heart dose is a correct surrogate for evaluating the chance of cardiotoxicity or late consequential cardiotoxicity, or whether we should use substructures. Because in the era of intensity modulated proton therapy, perhaps the mean heart dose is not really a good surrogate to use for evaluating plans. Particle therapy, as we all know, because it behaves quite differently from photon-based radiotherapy because of the Bragg peak phenomenon, which is familiar to the radiation oncologists in the audience. It has unique physical aspects, which helps us in limiting the dose to surrounding critical structures much better. The dose fall-off is very rapid. There is no exit dose literally to speak of, and therefore particle therapy remains a very exciting way of limiting toxicity as well as delivering higher doses. Now, despite the dosimetric advantages of proton therapy in sparing the heart, its correlation to cardiac event reduction remains to be defined, and that was the purpose of this study. And they have also looked at different models, different predictive models, which can sort of calculate based on the radiation dose received by the heart and its substructures as to which of these patients are going on to potentially develop cardiotoxicities as a consequence of the radiotherapy. There were two models which were importantly analyzed in this paper. One was the NTCP model developed by Darby et al. From the National Proton Therapy Working Group. Now, as we know, insurance remains a very, very important issue, and insurance approvals was what made these investigators embark on this study, primarily because they had to justify using proton therapy in the adjuvant breast cancer setting. So in Netherlands, they arrived at the conclusion that 2% absolute reduction in the risk of acute coronary events was the criteria which was analyzed, and they were trying to see whether it was achievable by using proton therapy as opposed to photon-based radiotherapy for breast cancer patients. And it became the basis for reimbursement since January 2019 in that country. Now, for the left-sided breast cancer patients, they obviously, as was expected, they found that the dose to the left anterior descending artery, the left ventricle, and the right ventricle was the maximum. Whereas for the right-sided breast cancer patients, the dose received by the right atrium, the right coronary artery, and the right ventricle was the most highest. Around 200 odd patients, 199 patients were taken up for the purpose. They were all post-operative IMRT patients under free breathing, and it was a typical mix of patients. For the left-sided breast cancers, they included whole breast radiotherapy with or without regional nodal irradiation and with or without internal mammary nodal irradiation, depending upon the indications thereof. And the right-sided breast cancers also had a mix of breast cancer radiotherapy and locoregional radiotherapy. Now, the Darby et al. Model estimated a 7.4% relative increase of acute cardiac events per gray of the mean heart dose. So it also uses the mean heart dose as a surrogate for consequential late cardiotoxicity. There is another model which was analyzed, and that was the Bogart et al. Model, which calculated the acute cardiac event risk at 9 years based on the mean heart dose or the volume of the left ventricle receiving 5 gray of cumulative dose. This also, interestingly, incorporated cardiac risk factors and including diabetes, hypertension, and previous ischemic cardiac events. So appears to be a more scientific model. We will go on to see how it sort of matches up to the Darby et al. Model or the other ATCP models. Sorry. So these are the typical distributions. The images on the top are basically from the proton therapy. The ones below are from photon-based radiotherapy. And as the audience can appreciate, the photon therapy definitely delivers more toxicity or more cardiac and pulmonary doses as opposed to the proton-based radiotherapy. This one basically compares, if you can look at the graphs with the green and the orange ones are for intensity modulated radiotherapy, which in the previous paper was used as one of the best techniques of delivering radiotherapy with the photons. And the green one is basically intensity modulated proton radiotherapy. As you can see, there is a significant difference in the mean heart dose with proton therapy as opposed to photon-based techniques, both with intensity modulation. This basically is a graph representing the reduction in the cumulative risk of acute cardiac events based on the different models that I mentioned. The NTCP model is in white, the Darby model is in red, and the one in blue is basically the Bogart model. As you can see, irrespective of the model used, we can see a uniform decrease in the range of potential predicted cardiotoxicity or acute cardiac events in proton-based intensity modulated radiotherapy as opposed to photon-based intensity modulated radiotherapy. The curves here, the ones on the top are basically the doses received by the heart with photon-based radiotherapy. The ones at the bottom are for intensity modulated proton-based radiotherapy. Across the board, all the numbers have got significant p-values in terms of reduction in cardiac dose, irrespective of technique. So, in conclusion, the authors said that IMPT or intensity modulated proton radiotherapy significantly reduces the dose to all the cardiac substructures, irrespective of the tumor laterality. Most notable for the left-sided breast cancer patients was with those who are having regional nodal irradiation also, and those with pre-existing cardiac risk factors. However, whether to use the mean heart dose or look at individual substructures is something that the authors have proposed but requires further follow-up. This is Madam's publication of the Indian experience on proton-based radiotherapy. I'll keep this short. Madam has published on 20 breast cancer patients. I don't know if there has been an update on that, ma'am. Please pardon me. This is the last one I could find. There are 20 odd patients who have been included here. 11 patients with breast conservation surgery and 9 with mastectomy. And it was interesting to see those prescriptions that Madam has used, which is in keeping with the conventions, but I was particularly interested in seeing how she has incorporated the boost into all of this. So what Madam's group has reported is that they use 40 gray equivalent to the whole breast in 15 fractions, which is more or less what is done for photon-based radiotherapy also. 48 gray equivalent as a simultaneous integrated boost to the tumor bed, and 37.5 gray to the nodal volumes. And the mean heart dose was practically insignificant. It was reported as 0.78 to 0.87 gray equivalent for all left-sided breast cancer patients. For the right-sided breast cancer patients, it tended to insignificant actually. And the left anterior descending artery, the max dose was 2.76 gray equivalent. The left anterior, the dose to 0.02 cc of the left anterior descending artery was 6.46 gray. This is the distribution. The first one is from the 20-degree gantry angle, the second is from the 40-degree gantry angle, and the third is a cumulative dose distribution of both of them. As you can see, it is basically an elegant dose distribution for the radiation oncologists in the audience, something I think you cannot really achieve with photon-based radiotherapy, which and these are different clinical scenarios which Madam has included. So the first one on the left is basically a breast conservation surgery adjuvant radiotherapy patient. The one on the right is basically a BCS, breast conservation surgery, right-sided breast cancer patient, sorry, the vice versa. The one on the left below is basically a breast reconstruction patient after mastectomy, and the one on the right below is basically a chest wall patient after mastectomy on the left side. So Madam's conclusion was that there was significant reduction in the cardiac dose received with intensity modulated proton radiotherapy or with proton radiotherapy as opposed to photon-based radiotherapy. She recommends, and her group recommends, that we use or we consider protons for patients with at least one coronary risk factor where the mean heart dose of 5 gray or more is predicted. And of course, they have also discussed the financial implications of this, particularly for the subgroup of patients who have coronary risk factors.
Can you conclude? Your time is up.
Yeah, I'm done. So it is recommended to use or consider proton-based radiotherapy for patients who have had one cardiac risk factor or patients in whom with photon-based radiotherapy the mean heart dose is more than 5 gray. Thank you very much. Thanks a lot.
For a change, we will allow the audience to ask questions rather than the chair commenting. Let us hear it from the horse's mouth itself, Dr. Sapna.
Ma'am, to be fair, I was expecting you to answer the questions, not ask them.
Thank you very much, Dr. Basu, for covering it so well. I'm not very sure whether we are addressing, but I think using helical tomotherapy and DIBH in helical tomotherapy was something that was very satisfying. I'm not very sure whether it's being covered later in the papers or not. But that was one thing that we started doing at the Proton Center, and that was something very, very satisfying.
Exactly.
As far as proton therapy is concerned, I think as radiation oncologists, it's very clear that if our principle is ALARA, there is no doubt that protons are better. And I think the issues are to do with access, with cost and with access. I think there is no dispute about the fact that the doses are remarkably less with proton therapy.
Absolutely, ma'am.
Right.
Yeah, also on the topic of DIBH, I did not have a 4D CT and we could not implement DIBH when we had the Tomo as our only machine. We are doing DIBH on a Versa HD platform, but my friend Suman and his team from Narayana Hospital have a series of publications on using DIBH with volumetric arc therapy, and they've done a very good job, and they have also reported excellent outcomes.
Thank you. We'll go to the next speaker.
Okay, our next topic will be the motion management in radiotherapy for breast cancer. That's very important technical aspect. Our speaker will be Dr. Monidipa Mondal. She is a consultant radiation oncologist, Narayana Hospital, Howrah.
Thank you, respected chairperson, for that introduction, and thank you, the organizer, for giving me the opportunity. So today my discussion will be one of the motion management strategies, which is deep inspiratory breath hold technique, focusing mainly on 2 studies. Next slide. Next slide, please. So we know that while radiotherapy improves the outcome in breast cancer, but the long-term survivor, they faces non-breast cancer related mortality, and that is mainly due to radiation-induced heart disease. And the quantification of this morbidity has been done by the seminal paper by Darby et al., which says that rates of major coronary event increased linearly with the mean dose of the heart with 7.4% per gray, and that there is no threshold about it. So the techniques has been described in the literature to decrease the mean heart dose, and the most widely used technique is the deep inspiratory breath hold technique. And the DIBH, for doing DIBH, there are different equipments which we use. One is the Varian RPM system. We use Electa ABC, and now there is the surface guided system, which is the Catalyst or Vision RT, Align RT. This has been used. Now there are certain challenges which we face with DIBH, and if those challenges are not met adequately, then it will compromise the benefit of the DIBH. One is that each patient is different, their breath holding capacity is different, and each breath hold will be different, because within a fraction of radiation, usually patient does breath holding for 4 to 5 times, and there will be intrafractional and interfractional variability in the breath hold, and so we should ensure the reproducibility as well as the stability of the breath hold for the success of the DIBH technique. Also, the workflow wise, there is slightly increase in the time for patient coaching, simulation, treatment time. It is definitely a resource heavy technique, and there might be some patients who show minimal benefit with DIBH because of the anatomical variations, and also specialized equipments are necessary. So our 2 papers which we are going to study, so they are going to take into account they are going to take into account one of the 2 challenges. So first is the large prospective data sets coming from the Germany Munich group, and this is the surface guided DIBH technique, and this is the Save Heart study, which included about 585 odd patients. So surface guided, surface based DIBH is the currently one of the newer technique, where real time motion management is done of the patient's external body surface, and this is done continuously, monitoring is done continuously during the treatment fractions, and it is done using the 3D optical cameras. So what it ensures is that it ensures real time intrafractional monitoring, and also ensures that the stability of the breath hold and reproducibility of the breath hold is there. So the methodology that has been described is that it is a prospective single center study, and it included left-sided breast cancer patients who have undergone breast conservation surgery or MRM and have indication for radiotherapy with or without regional nodal irradiation, and primary endpoint was to determine the heart dose reduction with DIBH. So this was the simulation scan that was done, using the Sentinel system for SGRT based DI based system. So first patient was trained, and then when the patient could take a stable breath hold, then a 4 millimeter gating window was set, and then there was projectors, and also there was some ceiling mounted cameras which captured the patient's surface in DI beige position, 3D patient surface in DI beige position, and this was taken as a reference scan. And after that, this simulation scan was taken both in free breathing and also in DI beige setting, and this was transferred in the TPS. Contouring was done, and both hyperfractionated and normofractionated RT was permitted, and the treatment was delivered using the same catalyst system of surface guided radiotherapy. So that reference image of the patient's body surface was matched during the treatment time, and if it is within the set limits, then it was allowed. If it is not within the set limits, then the beam was automatically turned off. So it was automatic gating was possible. Important thing which they did was that the baseline cardiovascular risk was also calculated by ProCam score, and the excess risk which the RT induced, that was also calculated in certain methods. So baseline patient characteristics was highlighted. It has to be pointed out that more than 10% of the patient had baseline characteristic of ProCam score more than 10% risk. And the key dosimetric finding was that mean heart dose was reduced by doing DI beige about 36 to 37%. LAD mean dose and also LAD max dose was reduced, and the ipsilateral lung mean dose was also reduced. And there was about 5% decrease in the 10-year cardiovascular disease risk with DI beige. This amount or this percentage might be very small, but clinically if we think, then this is going to be large. And so conclusion was that this was the largest SGRT DI beige study. Baseline risk was taken into account, and they have commented that DI beige should be done for all eligible patients of left-sided breast cancer. But the limitation was that SGRT is mainly looking into the stability or reproducibility or intrafractional variability. That was not analyzed in this study, and no direct comparison with other DI beige technique was done, and this was a single center experience. The second study was an Indian study where this was from Rajiv Gandhi Cancer Institute, and the main objective of this study was to not only evaluate the dosimetric benefit of DI beige over the free breathing, but also to see whether we can identify any anatomical or planning parameters which can direct us that we should be selecting which patient for DI beige or which patients are going to get maximal benefit of DI beige. So they did this study with this intent. And the method was similar. In this case, 100 patients were taken. Inclusion-exclusion criteria were more or less similar with the previous study. Variant RPM system was used for this, and IV contrast was given in both the scans. So they did both the scans in free breathing and DI beige to compare, and both conventional and hyperfractionated regimens were used. So these are the planning parameters which they selected for seeing which patients are going to benefit. And heart chest wall length and chest depth, heart height, this was calculated based on only on the CT scan. And when the other parameters like mean maximum heart distance and heart volume in the field, this was calculated after planning both in the free breathing and DI beige scans. So these are the patient's characteristics. Mostly the patients, 75% received regional nodal irradiations, and also most of them received hyperfractionated RT. So there was dosimetric improvement as that of the previous studies. Also LAD mean dose and left ventricular dose decreased with DI beige. But the main thing which they was looking into it was the predictors, anatomical predictors or dosimetric predictors which can predict the benefit of DI beige. So they found that the higher free breathing maximum heart distance or heart volume in the field, it actually predicted the benefit with DI beige. Also, the greater is the heart chest wall distance, the more is the benefit. This regression analysis, I am not going into it because this is not very clinically significant, though these were dosimetrically significant. So conclusion from this study is that DI beige reduces the cardiac and LAD doses, There are certain free breathing anatomical parameters which can predict DIBH dosimetry benefit and also can identify patients with maximal sparing. But main question, this was another study which we did in 2021, and it was exactly the same. Our parameters and objectives were exactly the same, and we usually found a cutoff of maximum heart distance. That is, if it is more than 1 centimeter, then there is going to be benefit with maximal benefit with DIBH. But why are we not following it? Because I think that this method is time and there is a time constraint for that, but because we have to plan in both the cities, in free breathing and DIBH, also there will be additional contouring, additional coaching of the patients. So it is resource intensive, and with this modern SGRT based DIBH system, I think we should not be selecting the patients. What I feel is that DIBH should be used for all
Please,
patients.
can you conclude?
Yes, so this is my last slide. It should be used for all the patients of left-sided breast cancers, if it is available.
Okay.
Thank you.
Thank you very much, Monidipa, for this informative talk. Anyone from Rajiv Gandhi Cancer Institute to comment about this talk?
Anyone in the audience let's comment on this? Okay, then thank you very much.
Thank you very much. Okay.
Can I call upon Dr. Tanveer Shahid, Senior Consultant and Head of Department of Radiation Oncology, Apollo Hospitals, Calcutta. He'll be talking about the mortality and MACE in patients with breast cancer and coronary inflammation and cardiovascular risk in cancer patients after RT.
Good afternoon, everyone. At the onset, I'd like to thank Dr. Vivek Agarwal, Dr. Purvesh Parekh sir for giving this opportunity. I'm going to speak on dose volume predictors of cardiotoxicity, moving beyond mean heart dose. So let's start with the positive note. We all do understand and accept that radiation therapy is an integral part in the treatment of breast cancer. No doubt about it, and this has been proved from multiple papers, studies, meta-analysis that radiation, it saves lives because it prevents the local recurrences. So every 4 local recurrences which we can prevent can save 1 life. But why we are concerned about is the concern is about the cardiac toxicity due to breast radiation. That's the topic. And basically the information came from this landmark paper published more than a decade ago by Sarah Darby, in which she showed that every 1 gray additional dose to cardiac can increase the coronary event, that major coronary event, to the tune of almost 7%. So that was something which was extremely alarming. If you look at the history and evolution of the radiation and the cardiac toxicity, in 80s, early 80s, 70s, 80s, that era, we did not know that what was the radiation dose going to the heart. After the publication of a seminal paper from Sarah Darby, we came to know that mean heart dose is a universal risk predictor. So once we knew MHD, ideally the cardiac toxicity would have settled down, but that did not happen. So even with the modern radiation also, we have the risk of cardiac toxicity, and therefore the concept of substructures dosing to the heart, that heart substructures, what is the radiation dose which is being given to those structures, that defines your toxicity. So this paper is extremely important for the reason it has been published from University Hospital Belgium, because by and large it was thought that after giving radiation, the screening program for cardiac toxicity should start only after 1 decade or so. But this paper showed what happens to the patients who take radiation in the first 1 decade. And what was very important to note was that cancer death is the most common cause, and it is very obvious. But second most important cause of death was cardiovascular death, and that was something extremely alarming. Even if you look at the major adverse cardiac events, heart failure, arrhythmias like atrial fibrillation and flutter happens in the first 1 decade, and we have to keep that thing in mind. And therefore it is very essential that we have to have a dedicated cardiological surveillance for the patient who take radiation even in the first decade. That was the crux of this particular paper. Why do we want to move beyond mean heart dose? The answer is very simple. Mean heart dose, it just ignores the functional and biological injury. It doesn't give any account of the cardiac strains and the inflammation inside the heart. It just gives you an average heart dose, that's all. It doesn't take into account any kind of hotspot on any one particular substructures of the heart. That is very, very important. Also, radiation is alone not the cause. The systemic therapy is also adding as a synergy or an additive. Again, mean heart dose doesn't take into account of all these structures. So therefore, we have to move from mean heart dose. Coming on to this, again a beautiful paper just published this year regarding coronary inflammation. This comes from the Oxford University. Number of patients were less, only 105 patients. Now, what is a simple way to understand coronary inflammation? Radiation exposure causes endothelial injury to the blood vessels in the heart. That causes inflammation, and that in turn causes fibrosis and atherosclerosis. This particular paper says it is not only the radiation which causes inflammation, but even the disease per se itself can cause inflammation. And radiation in some or other way, it can have some kind of a cardioprotective effect. But again, since the number of patients were very small, we cannot generalize this result into a general population. But what about the modern radiotherapy? Does it have a positive impact, or doesn't has any kind of a cardiac toxicity? Let us see. And again, a beautiful paper published from the University of Pennsylvania, and this happens to be the largest longitudinal prospective study in 300 patients where modern radiation therapy was given, and it was seen that how modern radiotherapy has an impact on heart function in relation to echocardiographic changes. Now, as a radiation oncologist, I did try to understand what are the different echocardiographic changes which an oncologist should understand, and there are many. In the paucity of time, will not be able to cover, but these all parameters are very important. And why this is important? Because if we happen to know this metrics, we can show a subclinical level that these patients can have a heart issue in the future despite having a mean heart dose low. So this is an extremely important slide. So what we understand is that it is not only the mean heart dose but something else, and that something else is LAD max dose. LAD max dose is the strongest predictor of strain, cardiac strain. That means heart failure can even happen with preserved ejection fraction. That we have to keep it in mind very clearly. Higher LAD dose correlates with lower ventricular ejection fraction, the lower longitudinal and circumferential strain. This parameters comes from the echocardiography, and worse diastolic function. MHD is less protective, less predictive, therefore we have to move from MHD. Practical implications, what we do in our daily practice. When we sit on a treatment planning system, this is something what we do as a daily practice. What is the mean heart dose? We see a value, 2 gray, 3 gray, 4 gray, depending upon like what Dr. Bonadipa told, DIBH versus no DIBH, and we accept the plan. Now, what we should ideally do? Ideally, we should contour all the substructures of heart as an exercise. I did it on my patients, and then we have taken snaps of it. You should contour the substructures to the heart, and then you should come down and know that what is the doses to the different substructures to the heart. And Dr. Sapna Nangia taught me that it is not only the LED dose, but there is something beyond. That is, what is the proximal LED dose? What is the distal LED dose? All these dose metrics has to be documented. Then, do we have any OAR risk constraint? I could find one, that is the German Society of Radiation Oncology risk constraint, which we can implement in our clinics. That is, again, it's for the hyperfractionation. Dr. Bonadipa has already covered this topic, that what is the result as far as the free breathing versus deep inspiratory breath hold is concerned. And the deep inspiratory breath hold definitely has a dosimetric advantage in the left-sided breast cancer the patients who take radiotherapy, and there's a significant advantage in the terms of dose. So to summarize it, mean heart dose is a landmark predictor, but mind it, it's an average. It's not a precise tool. Modern radiation and systemic therapy, they demand substructure assessment, that you have to look at the dose to the LAD, left ventricular dose, V5, V10. Then we should also look into the functional aspect of the heart, and that comes from the echocardiographic matrix and the MRI both, and as well as the CT based for knowing the anatomy. So therefore all these tools will give us a predictive value. And finally, obtain a baseline echo with a global longitudinal strain from the echo before radiation and follow-up. We as a radiation oncologists, we are hesitant to advise echocardiography, whereas medical oncologists, as a routine, they do so. So even radiation oncologists should learn from them. And then we should combine the anatomical dose, functional imaging, and the patient biology in order to come down to a conclusion. Thank you so much.
Okay, thank you very much, Tanu. I want to ask a question before the audience, because we are mainly focused on the left-sided heart structure, substructure. But even the right-sided radiotherapy, the heart will receive around 50 centigrade mean dose usually. Have you experienced any clinical significance of these right-sided radiotherapy patients?
So for that I will say one thing, that eyes do not see what mind does not know. By and large, for many of the factors, we leave it because the patient doesn't comes with, either the patient is already hypertensive, or if the patient develops a hypertension, we don't know. So therefore we never try to correlate that whether it is a radiation effect or not. So very honest I'll say is that we never look into those aspects, and we are not even aware of that. So by knowing this now, we have to be more aware so that we can try to correlate that what was the dose given and what is the effect because of it.
Okay, thank you.
I truly do not know how much you can give, save the lady or save the heart, without treating the cancer adequately. So prime thing is the treatment of the cancer, which is going to make the entire outcome. So though we can deliver focused radiation by whatever means, essentially the treatment of cancer should take the up. And so even if you measure the GLS or any kind of biomarkers, ultimately what we do to the treatment of cancer is more important. The investigations will help us to know whether we are going to have trouble. That is there. Dr. Manideepa, something you want to say before we close?
Just one thing I want to clarify, that when we are looking into the patients in our clinic, sir, what should be the actual investigation which we will be doing to look into the toxicity? Because all these patients are developing cardiac toxicity much later. You should be having a longer follow-up. But as you have said that in earlier days also, within 5 years also, patient can develop. And so whether we should be only doing echo or we should be doing other imagings to detect earlier about radiation-induced toxicities or any functional scan in practical purpose, because we are not doing any.
Dr. Sapna ma'am, would you like to take that answer? Question that what additional, because as of now, you do only echo, but do you do a CT-based fat attenuation index or cardiac MRI?
I'd just like to take, I'll go back to the question. The right side, if we see women, and there's so many cardiologists in the audience, I think the chairs will vouch for it, that women are more prone to develop right-sided, about 40% of women who undergo an angio may have right-sided coronary, involvement. So after radiotherapy for the right heart, the Swedish, in their national assessment, have seen that number increases from 40% of regular women undergoing angio, and if you have right-sided heart, right-sided radiation with internal mammary node irradiation and you undergo an angio, that number increases to 70% women having an abnormality in the right heart. So the right heart is definitely relevant. As far as some of the things that were mentioned earlier, Ayan, that there are studies which say that there are no cardiac events. But on the contrary, there is William Beaumont, which says about 6.5%. And then there's a Canadian prospective study. It's an Indian name, I'm forgetting right now. It's an Indian name. So they have looked and found 17% of left-sided breast cancer patients have some cardiac, it's not major cardiac events, that includes arrhythmias or pericarditis, etc., in the first 10 years.
We need to conclude.
Sorry.
Your time is
So
up.
the answer is no, it's still echocardiogram with GLS.
Okay, but what my co-chair really asked was the impact on the right breast, not right coronary artery.
No, when we are treating the right breast, we are impacting the right coronary artery. That is what my answer was about.
Okay, thank you. Let's close the session here unless nothing more to be asked. Let's move on.
Thank you so much, sir. We'll invite our next chairperson, Dr. Suman Malik, who is the Clinical Director, Chief of Radiation Oncology at Narayana Hospital, Howrah. I invite sir to the stage and I request him to please introduce our first speaker.
Hi, good morning. So we have already discussed a few interesting papers on radiotherapy, and we understand there are risks associated with radiation as well as chemo whenever we talk about cardiotoxicity, but always we balance between benefit and risk. So for next half an hour, so we have a few interesting topics to discuss, and those are on lung and esophageal artery radiotherapy. So first speaker is Dr. Amitav Ray, radiation oncologist from Chittaranjan National Cancer Institute, Newtown. So I'll request Dr. Amitav to be here. Yeah.
Thank you, Dr. Mullik. Thank you, Professor Parikh. Thank you, all the organizers of the second Asia Pacific Cardio-Oncology Summit for giving us the opportunity to speak here. Radiation oncologists have typically not been a very big part of cardio-oncology till date, but I'm sure with such conferences that's going to change very soon in the future. I'm so happy that I was assigned this topic about cardio-oncology, radiotherapy, arrhythmia after thoracic RT, because I look after the thoracic DMG in my institute. And I will argue that probably the largest load of radiation oncology departments at this point in time in India would probably be thoracic radiotherapy. It's very quickly surpassing head and neck and gynecological malignancies as a primary site, because lung, esophagus and breast seem to be outnumbering, as a group, outnumbering the radiation oncology in indications across the board in most departments. So I'll just start with this because this is not new. We have known about conduction system abnormalities with radiotherapy, and this paper published in the JAMA way back in 1981 actually gives us a case report of something that happened to a patient who received relatively lower doses of radiation but yet came with a complete AV block. With that in the background, it makes sense to actually look at all the cardiac diseases, the radiation-induced heart diseases that we actually look at. And historically, this has been the list. It has already been spoken of, so I will not bore you again by repeating everything, but just to remember that the latency periods of each of these could be as less as within 1 to 2 years to as long as maybe 5 to 10 years. So we'll only be looking at the conduction system abnormalities for the sake of today's presentation. So the question is, why study arrhythmia? The answer is very simple. This is a very insidious kind of a side effect, and it can lead to life-threatening events in a patient's lifetime. And so we need to be sure about what we are doing with the heart. And as I will show you subsequently, there are things in radiation oncology that can be done to at least try to prevent the incidence of atrial fibrillation at least, which seems to be the commonest cardiac arrhythmia that arises out of thoracic radiotherapy. To that end, we have some physiological basis, pathophysiological basis of doing what we are going to do. But having said that, all of this requires evidence, and that is the basic job that I have today, to show you the evidence as to how things are changing when it comes to predicting and preventing arrhythmias with radiotherapy to the thorax. Now, One of the most interesting studies and probably the most important study that I'll be talking to you about today was published in 2024 from the Stanford group. A very interesting work that they did, again thoracic oncology. Their subsites for treatment were non-small cell lung, followed by breast, Hodgkin's lymphoma and esophageal cancers. Those are the numbers if you want more details on that. And what they did observe, what the incidence of atrial fibrillation, this was all they were looking at. The incidence of atrial fibrillation seemed to differ across the primary subsites that were being treated. So highest for non-small cell lung, followed by esophagus, followed by breast, and last for Hodgkin's lymphoma. Now this is something probably a radiation oncologist, primarily a thoracic radiation oncologist, can predict, because the doses that are required across all of these indications are vastly different, as is the distance from the cardiac substructures to the area being radiated. So therefore, it makes kind of sense to understand that it will not be the same for every kind of cancer that we are treating in thoracic radiotherapy. The next question is, what exactly is being radiated which makes a difference, and are there any other factors that can predict for a higher incidence of atrial fibrillation? And beautifully illustrated in this study, what they found was the pulmonary vein maximum dose, or what we call the PVD max. The hazard ratio was 1.22 per 10 gray, and this was the most important, Dmax was the most important factor predicting for atrial fibrillation. And the other factors that were important was left atrial volume, smoking, and a higher Mayo AF risk score. Now this is where a radiation oncologist needs to probably update himself or herself, because that is not an area we usually look at when doing thoracic radiotherapy. What was the most important finding of the study, and something that we radiation oncologists have not been doing, is to look at PVD max and to get a dose which is considered threshold. Now for us, we always look at doses which are important from the clinical perspective, and the Stanford group was able to establish that if you can keep your PVD max to less than 39.7, approximately 40 gray, then you have a much lesser chance of that patient developing atrial fibrillation in the future. And as promised, for the radiation oncologist in the audience, this is the Mayo atrial fibrillation risk score. It's very, very simple, and so something that we all can introduce into our practice, especially people who are doing a lot of thoracic radiotherapy. Next, is that the only thing that we should be looking at, or are there other substructures which are equally important in trying to predict the kind of arrhythmia your patient might be developing in the future? Again, some fantastic work done by Atkins, published in 2022. Although no threshold doses were given here, but very beautifully they were able to show us that the type of arrhythmia a patient might develop, or conduction abnormality a patient might develop in the future, is a function of the doses being received to the various substructures of the heart. So atrial fibrillation, again, they were able to show that the pulmonary vein was important. For flutter, left circumflex. For supraventricular tachycardia, again the pulmonary vein, but the dose threshold here seemed to be higher. Bradyarrhythmia, right coronary artery, and ventricular asystole, LMCA, circumflex artery, is important. So there itself, we now see, as Dr. Tanveer, Dr. Monidepa, everybody was talking about earlier, this is just an add-on to that. It might not just be enough for us to look at even the anatomical substructures of the heart's anatomy, but also the vasculature of the various areas. This image very nicely shows you the mechanistic insight of what was published. So a low dose, low to moderate dose to the pulmonary vein predicts for atrial fibrillation or supraventricular tachycardia. A high LCX dose predicts for atrial flutter. RCA or AVN injury predicts for bradyarrhythmia, and LMCA exposure risk of ventricular tachycardia or asystole. So within that subgroup, now we have evidence that the substructure anatomies as well as the substructure doses now become important prospectively for us to now validate the tolerance doses, like has already been done for atrial fibrillation by the Stanford group. So please look out for this space in the future. I'm sure a lot of data is going to come in, and we radiation oncologists will have to take this up to make thoracic radiotherapy safer. But as was asked previously by one of our chairpersons, what can we do to actually monitor for these side effects? So as Sapna Madam rightly mentioned, there are no established guidelines as to what needs to be done, but work is being done in this area very actively. And this is a study out of France called the WATCH study, where they are basically trying many things, but the most interesting of what they're going to try is to try to see the arrhythmias with the help of the within scan watch system plus a 12-lead ECG over a defined period of time. Their results will be available in 2026, and that will tell us about or give us more directions about how to monitor our patients, especially undergoing thoracic radiotherapy in the future, to look out for any cardiac events, major, minor, arrhythmia, or any other type going forward. So if we integrate this data together, what do we get? So we get evidence, and very good quality evidence, that the pulmonary vein exposure is something that we need to start doing immediately. We also need to learn about deep learning, contouring. This is something that we don't do routinely, but something that's there in the horizon for, for help to contour the substructures of the heart. And something that I have been very fond of over my career, personalized dose metrics. So not every patient will have the same level of toxicity for a dose being delivered. There are personalization algorithms, and probably for the first time, the protocol for arrhythmia has now been established by the Stanford group. So something that in that regard needs to be done again and investigated in the future. And as is being done in today's conference, cardio-oncology collaboration with radiotherapy is something that we all should be doing. More so because it's not just about prevention of arrhythmia. Ventricular tachyarrhythmias are now being treated with radiotherapy, something that is now very popular across the world and something that probably we should also start doing in India. So the clinical takeaways for us radiation oncologists: to contour the pulmonary veins routinely during thoracic radiotherapy, keep the Dmax to less than 40 gray, incorporate cardiac risk scoring like the MAFRS for baseline prediction, consider digital screening tools, although we need to wait till 2026 to actually see whether this benefited, and strengthen links between dosimetry, arrhythmia monitoring, and long-term cardiology review, as has already been discussed in this conference. These probably are the future directions for us. We need to harmonize the institutions even within the city and try to find our own cardiac dose constraints. We need to adopt AI, something that we need to do on an emergency basis, and probably look at microanatomical arrhythmia zones in the future. We have to integrate wearable devices into radiotherapy for monitoring our patients in the future. And we radiation oncologists are extremely fond of guidelines. Probably it's time that the ISTRO, ASTRO, ESMO come up with the cardio-oncology guidelines that we all are waiting for. Thank you so much for your patient hearing. I'll take questions now.
Thank you, Amitabh. We can take one question from one question. No one. Okay. Thank you. So our next speaker, Dr. Akanksha Anup. So she will be talking on cardiotoxicity with IMRT versus proton in lung and esophageal cancers. Lung cancer.
Very good afternoon to everyone. Thank you for the warm introduction. So today we'll be discussing regarding radiation cardiotoxicity in lung cancer. Now, the earlier presentations were actually regarding breast, and these were the things that were asked in our residency, like cardiac doses and breast cancer. So Darby et al. Had already been our favorite paper. So this is a new topic that I have gone through and read it. So why is a sudden mention regarding lung cancer? Is because of the current treatment techniques that have suddenly come into the field that have actually given a better survival outcome, and hence we are getting the cardiotoxicity data for such patients. So broadly classifying, these are the major indications where we give radiation. So smaller tumors, we go for SBRT, which is 60 gray in 5 or 8 fractions depending upon the location of the tumor. And the second is definitive radiation for locally advanced either non-small cell or small cell cancers. Same dose but in 30 fractions. So why is there a sudden increase in the cardiotoxicity because of lung cancer radiation? So unlike breast cancer, the doses are higher in lung cancer. We are giving 60 gray. And secondly, the patients who come to us for radiation, they already have a few baseline cardiovascular risk factors that are present before starting radiation. So there are 2 papers that I'd be discussing. One is a retrospective analysis and the second one is the meta-analysis. So this paper It is a retrospective analysis of around 500 patients, that is 478 patients, which were evaluated. Their baseline cardiac parameters were depicted for radiation cardiotoxicity. And these patients were evaluated in a span of 5 years from 2015 to 2020. So apart from the other categories where the patients were separated in terms of stage and the nodal staging of the tumor, two major differentiation with which they correlated was already the cardiovascular risk factors that were present, that included diabetes, hypertension, dyslipidemia or smoking, and how did it correlate with the cardiac adverse events. That could be either arrhythmias, heart failure or coronary artery disease. So the discussion had already been done regarding mean heart dose, but what they actually also did was they contoured the substructure in their RT planning scan. So not only the entire heart, the substructure volume delineation was done, and then the volume was correlated with the dose received, hence leading to the cardiotoxicity. So coming to the results section, they had a median follow-up of 47.7 months. Median age of the patient was 70 years. 58% of the patients were planned with advanced technique. The mean heart dose that was received was around 7 gray. And 21% of the patients were already under cardiology care prior to starting radiation. Now, this was the Kaplan-Meier curve that was detected. So the left one, it actually shows that if a patient had a greater number of established cardiac disease, that is around 2 to 3, the incidence of the cardiac events increases to 55%, as compared to if a patient is having maybe 1 or 2 cardiac disease, it goes down to 16%, which was significant. However, for cardiovascular risk factors, there was not much of a difference. Like if a patient has 3 to 4 risk factors, the incidence will be 23%. And if it comes down to nil or 2, it comes down to around 17%, which was not significant. But these data, it actually did not extrapolate to overall survival. So there was no difference in overall survival. So this is a pictorial representation of how they formulated their results. So the A category, it shows the heart tumor relationship. That is, superior tumors are going to give low heart doses. So if our tumors are at the level of the heart or below it, then we should consider for substructure doses rather than just going for the mean heart dose. Secondly was the left atrium volume. So it was seen that if the volume of the left atrium increases from a certain median volume that they had given, I'll show it later on, it can correspond to atrial arrhythmia. So we need to minimize the radiation dose to the left atrium, and it can be followed up with serial ECGs when they come to the clinic. Another one was the left ventricle, where the increase in volume was leading to heart failure. So again, this is also a substructure dose which needs to be reduced in the left ventricle, and it again could be followed up with pro-BNP or NP. The last one which they suggested was a coronary artery, because doses to the coronary artery can lead to calcification, thereby leading to ischemic events. So how to minimize the radiation dose to the coronary arteries, and if it can be given an aspirin prophylaxis before starting radiation, that was a question. But it was seen that strangely the cumulative incidence of the cardiac events, it was not much different for the tumor regarding their location. Like for the superior tumors, it was around 23%, and for tumors below the heart, it was 19%. So there was no difference in the cardiac events relationship, or neither in the overall survival. So this is how they correlated the left atrial volume with arrhythmia. The left atrium volume median was around 98.1 ml. So it was seen that if the doses crossed, like if the left atrium volume increased, then the incidence also increases to 14% as compared to that of the 4%. So this was significant. However, there was not a significant association again with overall survival. Similarly, like left ventricle has been shown for heart failure, they actually found out that it's not just the left ventricle. The ratio of LV and RV is actually a clear depiction of heart failure. So what they calculated as an LVRV ratio was around 1.55. So increasing that ratio led to an increase in the cardiac events to 13%, and keeping to that ratio or going below it decreased it further to 6%. However, it was not strongly associated with overall survival. So hence this paper concluded that we first need to examine like what is the spatial relationship between the heart and the tumor in the context of the radiation cardiotoxicity. And two things like left atrium is a better predictor for arrhythmia, and left ventricular enlargement, which is indicative of cardiac pump dysfunction, is found to be associated with heart failure after radiation. Now the second paper, this was a meta-analysis of the dose volume predictors of cardiac adverse events after thoracic radiation. So two major trials for non-small cell and small cell has already shown that going above 60 gray is not much of value. As I had seen for non-small cell, like we went to 74 gray, but it was leading to a significant lower median survival of 20 months compared to that of 28 months for 60 gray. Similarly, for small cell, going up to 70 gray led to more grade 5 adverse events. So this paper highlighted that these four are the major cardiac events in the order of their importance. So pericardial effusion was reported in 43% of the papers, and arrhythmias in 17, heart failure, and then coronary artery syndrome. So what was the main takeaway message from this paper is that mean heart dose is still the best predictor. So if you could see the forest plot, it is the HR is 1.04. It means that for every gray in increase, it will lead to a 4% increase in the cardiac events, and the span being from 1 to 7%. But what this paper actually concluded, can only mean heart dose be the best predictor? So what are the confounding factors that were present in this paper was, there was no mention of the technique, like in most of the papers, like whether it was a 3D CRT or IMRT, going up to IMRT or VMAT, does it help in reducing the cardiotoxicity? Little or no mention of cardiovascular risk factors were present in most of the papers. And also, there was no mention of the concurrent chemo that is usually given along with radiation while planning for locally advanced lung cancers. The last question that they have just put forward to us is, does the presence of protons, so doing proton radiation, does it actually help in preventing cardiotoxicity? I don't have much experience in the papers that have come through, but would it be an answer in the future is what they have left us to think about with. Thank you.
Thank you, Akanksha. So, for interest of time, we are not taking any question. So, our next speaker is Dr. Atul Raut. He will be speaking on IMRT versus proton in lung and esophageal cancer.
A very warm good afternoon, all of you. Thank you for the organizing committee for the opportunity. I will be talking about the cardiotoxicity with IMRT versus proton in lung and esophageal cancer. So as we all know, in unresectable lung cancer, locally advanced lung cancer and unresectable esophageal cancer, definitive chemoradiotherapy is the standard treatment. In case of esophageal cancer, we can use it as a neoadjuvant therapy also. Lung and heart doses plays the vital role in this both conditions. So this is the first paper which was published in October 23, which discusses about the acute hospitalization after proton therapy versus IMRT in locally advanced lung cancer in durvalumab era. So this is a retrospective analysis to determine the association between proton beam therapy and unplanned hospitalization. It hypothesized that the PBT, that is proton beam therapy, would reduce the unplanned treatment related hospitalization compared to IMRT. Secondary objectives were various toxicities like pneumonitis, esophagitis, cardiac event, progression-free survival, and OS. So this study took place around 2017 to 2021. Patients were divided into proton therapy group and IMRT group. The mixed the studies mixed modality radiation plan were included in the PBT group when there was at least 50% of the plan included the proton therapy. Patient who received less than 60 gray or neoadjuvant or adjuvant RT without chemotherapy or thoracic re-irradiation were excluded from this study. The dose was around 60 to 70 gray. In this study, total 316 patients were included, out of which 37 received the proton therapy and 63% received the IMRT. Total 67.7% patient received the immunocheckpoint inhibitor. Median RT dose was 66.6 gray. In this diagram, we can see that mean hard dose in proton beam therapy group was 5.9 gray compared to IMRT group, that is 10.8 gray, which was statistically significant. Likewise, mean hard dose to left ventricle, left anterior descending artery, ascending aorta and descending aorta all were lower in proton therapy group compared to IMRT group. Coming to lung doses, mean lung dose was 14.7 gray in proton therapy group versus 15.7 in IMRT group, and lung V5 was also lesser in proton group versus IMRT group. Coming to the unplanned hospitalization, total 31 patients had unplanned hospitalization, of which around 29 patients, that is 29.6% patient were in the PBT group versus majority 70% were in the IMRT group. On multivariate analysis, it was found that grade 3 lymphopenia was lesser with proton therapy group, but when there was a higher nodal volume and greater GTV volume, it was associated with greater lymphopenia. With respect to other parameters, like there was no difference between proton beam therapy and IMRT in terms of grade 3 esophagitis, pneumonitis, cardiac event, PFS and OS. This graph shows the acute hospitalization within the 90 days of starting of RT. First graph shows the admission due to disease progression, in which we can see that there was slightly higher admission, that is 1.7% in the proton therapy group, but it was likely due to the higher age group in that group. Second graph shows the definitive or probably due to the radiation related toxicity, which shows that proton therapy group had the lesser admission compared to IMRT group. In third graph shows the possible toxicity due to radiation treatment. In this group also, proton therapy group had 7.7% patient admitted, whereas 12.6% in the IMRT group. The fourth graph shows the unlikely due to radiation toxicity, which were almost equal in both the graphs. So this graph shows the progression-free survival, overall survival and cumulative risk of a cardiac event, pneumonitis, esophagitis, which were not significant at 1 year. The limitation of this study was it was non-randomized, a retrospective study. Reason for hospitalization were identified non-blinded, manual chart review, which may be subject to observer bias, and IPTV was associated with balance, was used to associate balance between the two groups, but this was not statistical approach to account unmeasured confounders. The second study is the long-term prospective outcome about the IMRT in locally advanced lung cancer. It's the secondary analysis of RTOG 617 study. It compares the long-term outcome of patients receiving IMRT with 3D CRT. Total 483 patients were included in this study. Long-term outcome in terms of overall survival, progression-free survival, time to local failure, developmental to second cancer and severe grade 3 toxicity were assessed in this paper. In this paper, total 483 patients were included, out of which 47 patients were treated with IMRT and 53 with 3D CRT. Median hard dose, that is V40 gray, was 16.5% in IMRT group versus 20.5% 3D CRT group, which was less. Similarly, lung doses were lesser in the IMRT group compared to 3D CRT group. At 5-year median survivors, IMRT and 3D CRT had similar PFS, OFS and other parameters. The hard dose, that is V20 and V16, was associated with survival, and hard V40 less than 20% was associated significantly with better survival than hard V40 greater than 20%. On multivariate analysis, hard V40 more than 20% was significantly associated with the worse hard survival. This study shows that IMRT was associated with significant twofold reduction in the grade 3 pneumonitis compared to 3D CRT, and V-lung 5 was not associated with the more than grade 3 pneumonitis, esophagitis and other toxicity. This paper concluded that the IMRT is the standard treatment for locally advanced lung cancer, and IMRT should aim to minimize lung V20 and heart V20 to V60. The third paper is the meta-analysis about the efficacy and safety of proton therapy and photon therapy in patients with esophageal cancer. The objective was to evaluate whether proton therapy was beneficial compared to photon therapy in terms of dosimetric, prognostic and toxic effect outcome. Secondary objective were to assess the efficacy and safety of proton therapy in single pool analysis. So this meta-analysis was conducted for between 2021 to 2023. The studies included at least 10 patients were included in this meta-analysis. Most recently published studies were included. The studies which had mixed assessment, previous history of radiation and mixed proton and photon therapy were excluded from this meta-analysis. Coming to the results, total 45 studies were included in this meta-analysis. 31 had the dosimetric comparison, 17 had the photon versus proton comparison, 10 had the studies had photon therapy, and 3 studies used propensity match score. Coming to dosimetry comparison, the proton therapy was associated significantly reduced mean dose to the lung compared to photon therapy. These are some of the volumes which were lesser in proton therapy group compared to photon therapy group. Overall, there was a mean dose reduction in lung, that is 4.4 gray. Coming to heart doses, there was significant reduction in the mean heart dose compared to photon therapy. There were various volumes were lesser in the proton group compared to photon group, and mean dose of heart was 9.5 gray. There was a reduction of 9.5 gray in mean heart dose. Coming to the efficacy and safety of proton versus photon therapy, the pooled analysis OS found that there was worse for OS for photon versus proton therapy. Pooled analysis for PFS also showed the same, worse for the radical therapy group. This paper had some limitation, that is that are significant heterogeneity in the doses of OAR in terms of dosimetric analysis. The studies were included with patients, smaller number of patients, likely 10 patients. The data description was included in the study were not detailed and did not pay any attention to any prognostic metrics, that is local control, distant metastasis and other toxic effect. This study concluded that proton therapy was associated significantly reduced OAR doses, and proton therapy was associated with significantly improved prognosis and toxic effect. Thank you.
Thank you, Dr. Atul. We can take question at the time of panel discussion. So it's my pleasure to welcome Dr. Indu Bansal Agarwal. So she is a group director and HOD of Department of Radiation Oncology, Paras Health, Gurugram. So I'd like to request Dr. Indu to introduce her panelists. So there is one change. Instead of Dr. Kaushik Chatterjee, Dr. Ayan Basu is requested to be in the panel.
Good afternoon, everyone. At the outset, I would like to thank Dr. Purvish Parikh sir, Dr. Vivek and everyone else in the ACOS organizing committee for having me here. I think we are having very wonderful sessions on cardio-oncology, and I'm really impressed with the level of talks today. So I am going to talk about cardiotoxicity and radiotherapy, and we are conducting a panel, and I have the privilege of inviting none other than Dr. Sapna Nangia, who needs no introduction. She is at the Apollo Proton Center, and we have Dr. Aparna Srivastava, who is the Senior Consultant and Medical Oncologist in Narayana Health, Shimoga. We have Dr. Ayan Basu, Clinical Director, Radiation Oncology, Peerless Hospital, Kolkata, and we heard him and it was a very beautiful talk by him. Basically we have 2 radiation oncologists and 1 medical oncologist. If some cardiologists can also join us, then it would be
Ma'am, we also
wonderful.
have Dr. Dipanjan Majumdar as well.
Dr.
He's a,
Dipanjan, you said he's not there, no?
that was Dr.
Okay.
Kaushik.
Dr.
Dr. Dipanjan
Dipanjan,
is
I'm
here.
sorry,
Yeah,
Dr.
yeah.
Dipanjan. Dr. Dipanjan Mazumdar is also a radiation oncologist. So, can we have some cardiologist also in the panel? Can I request someone? Dr. Rakesh, will you please help us? Thank you so much. Thank you. So, cardiotoxicity and radiotherapy, दिल का मामला है, protect तो करना ही पड़ेगा. So, we know that there is radiation induced heart disease is what we will be talking about today, and we will be talking about risk factors, pathophysiology, what are the methods for early detection and how to mitigate and prevent them. So I would like to ask Dr. Sapna ma'am, what are the factors associated with cardiotoxicity? Is it only radiation? Like we have been listening only to the radiation part, so it seems like that radiation is सब कुछ नुकसान कर रहा है. I mean, is it, what are the factors associated apart from radiation?
Thank you, Indu. I think that's a very pertinent question. I think we have to understand that radiation, the impact of radiation is related to the baseline risk of the patient. So the baseline risk of the patient is very, very important. And that would mean factors such as diabetes, hypertension, the various other factors that have been covered by Darby et al. For example, the need for anti-inflammatory drugs, long-term need, or previous ischemic heart disease. And besides that would be the administration of cardiotoxic agents, adriamycin and trastuzumab. There is also some evidence of previous history, family history of cardiac disease also being important.
So I think that's very rightly said. So we can divide them into patient-related factors, tumor-related factors, and treatment-related factors. So patient-related factors are age itself is a risk factor. Dr. Sapna said also told that females are more at risk. Then family history of cardiac disease, personal history of cardiac conditions, hypertension, hypercholesterolemia, diabetes. Smoking history is also very, very important. And there are tumor related factors like target tumor volume and proximity to the heart, target volume size, stage of cancer and prognosis of cancer, and treatment related factors like what all systemic agents the patient has received, total radiation dose, dose per fraction of radiation, and volume of heart receiving the radiation dose. The technique of radiation which is being used, has the patient received any previous thoracic radiation, and cumulative cardiac doses in the treatment? Are we using any image guidance, or are we using any latest techniques like proton treatments or heavy ions or DIBH? So all these also are important. So I think Dr. Tanveer covered this part. What are the heart regions associated with radiation induced heart disease? So I would like to ask Dr. Dipanjan, in your clinical practice as a radiation oncologist, we are very much focused about LAD and mean heart dose for breast cancer patients. But in your routine practice for esophageal cancers or for lung cancers, do you routinely mark all the cardiac substructures, and or do you give different dose constraints to them?
To be very frank with you, that we are not in our routine practice still use the cardiac substructure dose volume thresholding, and actually we stick to the conventional dose matrix like the mean heart dose. But with the present relation, other matrices, specifically of some atrial fibrillation and the heart failure and all the other clinical metrics which has been studied and has been reported to be associated with the different doses like the pulmonary vein dose and the left right-sided heart dose and these things. So presently it makes some sense to change our practice and to report these things, and till now even we are not practicing exact putting some threshold, but at least to report this thing whether and to follow this patient with some robust sort of cardiac imaging if it is available, so we can actually find some sort of the clinical or detect some sort of the clinical differences which actually we are not really looking at. Because whenever we are seeing the patients in our follow-up OPDs, we are not doing many sort of the investigations related to or assess some sort of the cardiotoxicity, because we are actually been type of actually seen in previous sort of the clinical practice that probably the clinical outcome, we have actually fed with this thought that probably the clinical outcome is not that much detrimental, even if whatever sort of the cardiac matrices we are following in our thresholding or we are following in our practice in terms of the plan evaluation. But I think it is our sort of look, we should be looking forward to do the cardiac substructure dose follow-up and try to establish or try to find if anything clinically significant we can actually establish.
So I think that's a very important point made. So I think this is the learning for us radiation oncologists as well, that I mean, the meetings like this, they have ignited something inside all of us that we have to mark the substructure. So for breast we were doing routinely, but honestly when I was not doing for esophageal or lung cancer, so I admit it here.
Can you just say something? Like how frequently you can avoid so-called LAD or RCA or anything when you have to treat the cancer itself?
Yeah.
So when we say we can protect heart, we say even if you go near LAD itself or near heart itself, even if the field is not involving the heart, still the inflammation can spread. We have seen GLS abnormalities in patients who are treated where the heart is not directly in the field, but still the GLS is abnormal. So I'm really surprised at how you people do treat the cancer by protecting these organs. However, you can avoid the cardiac structure.
So I think that's one is that awareness is very, very important. If we are aware that these things can happen, then we are more cautious. Like for LAD, now most of the centers for left-sided breast cancer patients, we are doing DIBH or gating techniques, or like for esophageal cancers, we do 4D CT or we use DIBH even in those cases. So awareness is very, very important, and I think pre-treatment evaluation by a cardiologist is something that we all need to start doing. So this is a slide which shows what are the heart regions which are associated with radiation-induced cardiac disease. It's not just the base of the heart, but it's the pericardium, superior vena cava, right atrium, pulmonary artery, coronary artery, then left atrium, left ventricle, LAD, ventricles, and there are different doses and there are multiple papers, and we have been listening to all of these papers since morning. So I would like to know from Dr. Ayan, what is the mechanism of cardiotoxicity? Why does it actually happen?
Ma'am, that is again a matter of speculation, but before we get to this, there's just one pertinent question. Am I permitted to ask a question?
Please put your mic.
It's not often that you get an opportunity to ask questions to Dr. Nangia, so since she's on the panel. One thing that we need to note is that for breast cancer adjuvant radiotherapy, all of us radiation oncologists have migrated from the conventional fractionation to more and more hyperfractionated regimens. And we're also doing things like accelerated partial breast irradiation and smaller volumes and more hyperfractionation. So dose per fraction, as you rightly mentioned, might have some implication in terms of consequential late cardiotoxicity. What, in your experience, ma'am, is, we have migrated to 15 fraction radiotherapy as standard adjuvant for breast. Does it have an implication in terms of late cardiac toxicity?
That's a very good question.
So as we understand, it possibly doesn't. And it seems to be safe to move to 40 and 15. How it will pan out in the 25 gray fraction is difficult to say. But in my practice, both for photons as well as protons, doing whole breast radiation and nodal radiation and a simultaneous integrated boost has happened, I should say, quite smoothly. There's only one, if I may be permitted, only one thing that we changed between protons and photons is that I reduced the boost dose a little bit. So from 48 in the initial paper, we came down to 45.6, which is one fraction less, because we had 2 patients who had some sort of radiation recall or an inflammation, and since then we have not had any such issue. But no, moving to hypofractionation doesn't seem to have had any negative impact.
I think this will be a very interesting space to watch, like radiation, I mean dose per fraction, will it actually lead to late cardiac events? So honestly, I have not searched any papers on this, but we might get something. So that's a food for thought now. So I think as per the mechanism of radiation toxicity for the medical oncologist, radiation leads to DNA damage and it leads to oxidative stress, which leads to endothelial cell senescence and release of pro-inflammatory cytokines like interleukin 1, interleukin 6, interleukin 8, tumor necrosis factor alpha, and radiation ROS, and pro-inflammatory cell recruitment and adhesion happens, which leads to release of thrombin, which leads to prothrombotic state leading to thrombosis. There is increased glycolysis, and there is atherosclerosis and intimal thickening, altered mitochondrial oxidation leading to fibrin deposition, altered lipid metabolism leading to lipid accumulation, and immune cell activation, which leads to inflammation, as rightly pointed out by Dr. Gopal. So radiation-induced heart disease includes CAD, cardiomyopathy, pericardial disease, valvular disease, and conduction abnormalities. So, so if there is pericardial inflammation, it would lead to pericardial effusion and constrictive pericarditis. If there is fibrosis of myocardium, it could lead to diastolic failure. Valvular dysfunction can also lead to diastolic failure. Valvular dysfunction will lead to arrhythmias, regurgitation, or stenosis. There can be fibrosis of the electrical conduction system and endothelial damage in the coronary vessels, leading to atherosclerosis or coronary artery disease. So I want to ask Dr. Aparna, what are the strategies used for cardiac assessment? Like as a medical oncologist, you routinely do echo, but do you do anything else apart from echo?
So as per the guidelines, it's not only echo or ECG, we are supposed to do even troponin and NT-proBNP starting right from when we start chemotherapy.
In every patient?
In every patient, especially for breast cancer, we are always using doxorubicin, and it is mandatory to do troponin and NT-proBNP. And one more thing is that in one of the papers also it was mentioned that this ASCVD risk factor is also very important. So we should not only think only about, from morning we have been listening to radiation, doxorubicin, trastuzumab. We have forgotten about menopause. We have forgotten about the endocrine therapy which makes the person menopausal. And they have a patient who has cancer also has other risk factors like aging and inflammation, oxidative stress. So I think it is very important we should start cardiac assessment right from the beginning. But the problem we face in every institute is cardiologists are already busy with acute cases of MI. They are having a full house OPD. And when I send a patient to cardiac OPD, they ask me, why are you sending? Because everything is normal. So what we do is we do the things like lipid profile and NT-proBNP, echo, and if there is anything, if we see that GLS there is an abnormality, then we tell them that because there is high LDL, we are sending you for something like primary prevention, or you treat all the other risk factors, like there is hypertension, you treat the hypertension. So it's a challenge because I'm not blaming the cardiologist. My husband is a cardiologist himself. So I see how
you can blame him. That's fine.
So I think it is very important not only in the survivorship or late effects, right from day one. I think it's important and whatever happens, like you said that RT, I learnt about two sorts of radiotherapy induced problems. One is like in breast cancer, it happens after 10 years or 15 years, and like in thoracic RT, you start and like next month or 2 months later they develop cardiotoxicity or pneumonitis.
Fibrillation normally happens within 2 years as per the paper.
Yes, yeah. So there can be early or late toxicity. So the patients have this habit of blaming the treatment, like okay, this was given, that's why this happened. So I think from the beginning we should sensitize them that they have these cardiac risk factors, and that itself can cause MI anyway. These days, people have MI even without any risk factor also. Like things like high sensitive CRP, that they are all very
Gopal, would you like
important.
to add something? I mean, it's a
markers-
basic workup. Do you feel as a radiation oncologist and as medical oncologist we should be doing for a patient with say breast cancer, lung, esophagus, and upper, distal esophagus or upper stomach cancers, or say for patients with Hodgkin lymphoma. See, normally what we see is echo, and in most of the echos even GLS is not mentioned. I mean, so many times it's not mentioned, and we don't know how to interpret it. So what should be the cautionary things that which should make us alert on an echo report?
See, the thing is, like, first thing I want to list, there's no indication to do routine markers or stress testing in a person who is asymptomatic. And is it, let me
There was
complete,
a guideline, sir. This
yeah.
Euro PCR,
Yeah, it's just
European.
routinely you don't do stress tests, routinely you don't do cardiac imaging.
Stress tests,
And
sir.
the thing, if you say people without risk factors develop cardiac problems, that's not completely true. But one thing I want to make to tell everybody is that you cannot run a cardio-oncology program without creating a team. A cardiologist or oncologist is not enough. You need sonographers who are trained particularly in cardio-oncology, especially in GLS. They should be able to tell something is artifactual or not. They should be interpretable. Second thing, you need communicators to the patients. You need nurses. You need somebody to take a patient's call 24 hours a day. So we have some four phone numbers where everything is being answered. I mean, I shouldn't say this, but we run one of the largest cardio-oncology program in the world. We have huge number of people. I travel with my people wherever I go. We have sonologists, we have physician assistants, we have nurses, we have doctors, junior doctors, and it is huge. That's the only way you can run. As you said, you send a patient to a cardiologist, he won't be interested to see it. Okay, so the work should go on. So everyone should be empowered, and everyone's work should be recognized, and everyone must be trained. I bring these people everywhere because I want them to learn. That's the only way you can run a program.
So would you suggest one basic workup that we should do?
All of them should have a detailed history,
Yeah.
effort tolerance, then risk factors which are conventional, especially in those people who have breast cancer, those people who have prostatic cancer. If you look at the risk factors for any cancer, it is same as cardiac risk factors. So the risk factor assessment is for everyone, diet control is for everyone, physical activity is for everyone, and imaging is to be tailored for the patient. If you do imaging and if you do biomarkers unnecessarily, you will end up not giving chemotherapy. Even DPYD, if you want to do for everyone who is going to reserve S1 or 5FU, capecitabine, you will end up giving no chemotherapy to many people. Reason is the gene is incompletely expressed and its penetrance is variant. So we should be very careful about using these parameters. But the basic things are for everyone. But more than anything else, there should be somebody to communicate to the patient. Patient might even ask you, can I take Coca-Cola? Can I take fruit juice? Can I take something else? These are all to be answered. So a team is very important. Without a team, cardio-oncology will never work. I'm 100% sure.
So I just made this slide, I mean, for my understanding, but please clarify it more. So like the echo, the strength is that stress echo is highly specific for ischemia and it's best for valve assessment, but it has limitation in coronary disease assessment and may not detect the non-obstructive coronary artery disease. Similarly, cardiac MRI, the strength is, it is sensitive for ischemia assessment, myocardial fibrosis and pericardial assessment, but may not detect non-obstructive CAD. And CT is best for coronary artery assessment and pericardial assessment and for structural procedures, but it has limited expertise is available and minimal radiation exposure is there. And strength is technique to assess ischemia but may not detect non-obstructive CAD. So none of these is able to detect non-obstructive CAD.
This is a very nice thing. This is a very nice slide you have shown. The main thing it is, see, the chronic stable coronary artery disease is one of the most benign disease on earth. Though CAD is called, not called malignant, that should be called malignant if it is an acute coronary syndrome. An acute coronary syndrome is the dangerous thing because people who develop acute coronary syndromes, 50% will not reach hospital. They will die. That is the most malignant disease. You should not call probably cancer as malignant. That acute coronary syndrome is the most malignant thing. At the same time, chronic stable CAD is the most benign disease. If I do angiography for everybody sitting here, you will find many of them having plaques, disease, everything. But that won't kill. Here, the stress testing can be done in echo by doing two-dimensional stress echo. In MRI, you can do stress. In CT angiography, you can actually do the functional flow reserve by CT itself, PET scan. But that is not very important. The risk factor modification is for everyone, not just people with cancer. Without cancer also, risk factor modification is for everyone. Physical activity is for everyone. Cessation of smoking is 100% for everyone. At the same time, we should use other imaging parameters as per the patient and tailor to them.
I think very rightly answered. So we will not, yeah.
I think so. What we understand today is that the most important thing, the time a person takes chemotherapy and all is, it is a good history, because that tells a lot. Because with good history, you can really find out that is the person having any underlying cardiac issues or not. Very rightly said, you don't do imaging for each and everybody. It is not required to, and obviously stress test is not needed. But if a person says that he's walking for good around 3 kilometers every day in half an hour and he is having a good exercise tolerance, the chances of his having underlying significant coronary artery disease would definitely be low. Now coming to an MR, you can't do an MR for EF estimation all the time. It is difficult, and you can only do it once. But we tend to do a sequential testing with echo. Now the problem with echo is that most of the echoes, they are done only for systolic functions. You hardly do a GLS, you hardly as such the diastolic functions. The diastolic dysfunction itself is a marker that, okay, the person is having some cardiotoxicity. It may be the first thing which you may find out, and subsequently the systolic dysfunction comes in. So it is important that lead should be placed the time we are doing an echo, and GLS also. When we do an echo, GLS should definitely be incorporated, and because in sequential testing, it is a GLS which would tell that, okay, things are going down. You can have us look at the subclinical dysfunction, myocardial dysfunction with GLS rather than just EF.
See, the GLS per se has not improved prognosis in patients who are getting chemotherapy. GLS is important in people who have myocarditis, immune myocarditis. It's important in people who have cardiac amyloidosis. All other things that GLS drop alone cannot make any clinical decision. That's not, because in that again you will be stopping the chemotherapy unnecessarily. But if you, GLS, the most important thing is to say that this is actual result. For that you need training, you need people. And if any of your technicians want to learn GLS, please send to us, they are welcome. 1 or 2 days is good enough.
So I think I will not talk much about heart because we have discussed a lot since morning and this slide has been shown by everyone, so I'm skipping this. Dr. Ayan, what are the strategies you are using for cardiac protection?
If you do not have access to particle therapy, if you are using photons, and if you have, you can have two types of accelerators which are in common use nowadays. One would be the C-arm-based Linex, obviously. Their DIBH has shown a significant impact in terms of decreasing the mean heart dose. And there are many elegant publications, including by my friends from Narayana, where they have shown that with the use of DIBH, you can push the treated volume away from the heart and therefore significantly reduce the MHD, which can have implications in terms of reducing the late cardiotoxicity.
Prone in any of your patients?
We have tried in 1 or 2 patients who have pendulous breasts, but it's very difficult to replicate. So the oncological outcomes is an area of concern in those patients. There are centers which are doing prone routinely, particularly several European centers for obese patients or patients with pendulous breasts, and they have reported very good outcomes. Our experience was not the same. The other thing is, if you have a helical tomotherapy like rotational ring entry technique, then obviously DIBH can be implemented, as Madam has pointed out, and again, while it conforms the dose very well, you can achieve very rapid dose fall off. And you can also, with implementation of DIBH, reduce the cardiac dose, which can definitely help. And again, particle therapy, of course.
Dr. Sapna, I would like, you have a very good presentation. I mean, you have a very good data on proton treatment. I think I've brought this slide. Sorry. Okay, yeah. So my question is, now that most of the centers don't have proton treatment, but like if someone has a tomotherapy and they are doing DIBH for left-sided breast cancers, and we are able to reduce the mean heart dose or LAD dose. So is there any particular patient where you would definitely want कि इसमें तो proton ही करना है? I mean, any specific indications? And like what I read was that for lung cancers, if suppose we are treating lung cancer patients where you have to treat the nodal area also, and on the left-sided diseases there, but if it's a right-sided lung cancer where you have to do SBRT, then maybe heart doses will not be much of a concern. Similarly, the mid and distal third esophagus is one area where maybe heart protection would be better with protons, or patients with underlying cardiac problems. So can you give us a take home this thing that these patients you should definitely refer for protons?
Actually, I'd just like to divide my answer into 3 parts. Number 1, when we talk about 7.4 per gray, let's also look a little more deeply into Darby's data, and what it says is that it's 16.5% per gray in the first 10 years. So that is something that is not techniques? Often 16 or 16.5.
But that data was that was up to 1971 to 1979, where
this is the entire data. When we see the first 9 years, the risk is at 16.5% per gray. So there is a slight difference. It's not so that is in the 10-year risk, right? That is one. Second, I think helical tomotherapy actually requires. When we do DIBH and helical tomotherapy, till very recently, the vendor was not offering that, and it has many things that we need to look into because the treatment is being done helically, and in fact, we have done some work on that. I have designed and used a frame which is actually patented, and we have published our data on that too. It would be of interest to the radiation oncologists. And the third, who is the patient who would benefit the most? I think the patient who would benefit the most would be the patient who has a good long-term prognosis, but also has high-risk factors such as diabetes, obesity, hypertension, and requires internal mammary node irradiation, or has ILD or some place. So, and as far as the internal mammary node irradiation is concerned, that would be irrespective of the side, whether it is right or left. But typically, the best outcomes or best sparing would be in the left-sided breast cancer patient.
I think in the interest of time, we would go to the last question, although I have too many questions to ask. But okay. So yeah, this I'll ask to Dr. Ayan. Dr. Ayan, which cardiac devices do you think need protection during radiation? We all know about pacemakers, we know about cardiac implantable devices, but
regarding
like
the pacemakers, there are now guidelines.
With TAVR, would you do cardiac protection?
I'm not really aware of the guidelines regarding the stents. Regarding the pacemakers, there are now guidelines.
TAVR is inert.
That's an inert.
TAVR is inert, so no need to protect.
Dr. Dipanjan, you want to add something?
No, I also know about the pacemaker sort of because I am not aware about the other stents and everything.
So I made this slide actually. I just gathered that did a lot of research for this. So basically the cardiac devices which need protection during radiation is pacemakers. They need protection. It's a high priority because it can lead to electronic malfunction. The dose limit should be less than 2 gray. ICDs, high priority because it can lead to sensitive memory plus CMI and neutron effects. Then CRT-P and CRT-D, they are similar to pacemakers and ICDs. Try to keep the dose limit less than 2 gray, avoid beams more than 10 MV to reduce neutrons, and you should do a device interrogation before, mid-treatment and after completion. For LVAD and RVAD, its protection is critical because it contains life support electronics, because it contains electronic controllers, batteries, circuit boards which can be affected by cumulative radiation, and malfunction is life-threatening. It's often placed subdiaphragmatically in the left upper abdomen. So thoracic and upper abdominal artery are also relevant. Try to keep the doses typically below less than 2 to 3 gray, and try to keep dose to pump and controller also as low as possible. Avoid direct beams to the controller and battery pack. And for implantable loop recorders, you need protection because it can lead to electronic interference. The dose limit is less than 5 gray. For stents, mechanical bioprosthetic valves like TAVR and Watchman occlusion devices, you don't need any protection. So these are the cardiac devices which need protection: pacemakers, ICD, CRTP, CRTD. So they are classified into low risk, medium risk and high risk, and depending on that you do the dose reduction. And for left ventricular assistive devices, again, I mean, there are different dose limits for pump housing, for controller and cable, and for battery pack. So ideally you should be marking all of them separately and not as a single organ. Like when we mark a pacemaker, we mark it as a whole. But if you are marking these LVADs, then they should be marked separately. So we have to read the literature and the pamphlet that comes with it and give separate dose constraints. Sir, you want to add something?
What do you mean by mark separately?
So when we are doing radiation contouring, then we mark we mark different substructures for the heart. So similarly, if there is a left ventricular assistive device, then we have to mark the battery as a separate organ at risk, the controller and cable and battery pack.
What we do is basically we interrogate the device, and then change the mode, and then reprogram after that. That's what actually we do. And among the implantable in the pacemakers, in monitors, it only interferes with the recording. Nothing else it does. Rather, nitinol kind of material like they used in TAVI and all or ASD device closures, they don't need anything particularly. That's a.
So every day we used to face this problem. So I thought I'll search it and make a table. So, and these are the cardiac substructure dose constraints. Just I tried to make one table for everyone. I think with in the interest of time, I would like to stop it here. And
I'm really getting curious about who is this Darby. I've heard of George flying the plane as an autopilot, and so I need to research who is this Darby.
I wish I was her. So thank you to my esteemed panelists. I think Dr. Sapna is doing, just last thing. Ma'am, you are doing something interesting that we just talked, that you have done something on hypothesis generating that Indian patients, they have a different tolerance and
thank you,
Indu, I would like you to comment on that.
Giving me the time to just talk about it. This is some new work that we have done. We've hypothesized that patients and doctors want to know what is the absolute risk of a patient, right? We talk about 7.4% per gray relative over the baseline. So I have hypothesized, and it has been accepted by the Red Journal. We should see it in print, online in the next 1 month or so, is that we could calculate the baseline risk of a patient using the Q risk formula, which is used by the NHS for 10-year risk and lifetime risk. And in that, interestingly, when you do the Q risk formula calculations, we find that Indians have a higher risk of developing cardiac disease in 10 years, in the first 10 years. If you compare a white woman who has X characteristics, the Indian patient will have a 10 to 20% higher risk of developing a cardiac problem. And therefore, the permissible dose for an Indian patient should actually be marginally less.
It's so interesting. Dr. Aparna, you are also doing something interesting on atherosclerosis.
Yes,
so last comment by you, and then we'll close.
So we have a cohort of 150 breast cancer survivors, and we are serially following them. And it was seen that our longest follow-up is 8 years. So maybe in the next decade they may develop problems, but we are using CT coronary calcium score as a risk factor, and it was seen, it was very interesting that we saw that patients who took RT and patients who didn't take RT had similar coronary calcium score. So we were wondering why even patients who didn't receive radiation are also having coronary calcium, and they were taking endocrine therapy, they had taken doxorubicin, they were older, they had diabetes. So I think we cannot put only radiotherapy as the culprit, because it's a multifactorial disease.
Coronary calcium scoring is altogether a different business. It's not like only after radiation. Coronary calcium scoring is even done for young patient who comes with chest pain, OPD, and we do it. And I'm not a fan of that in that way, but not the way you are telling. But no, it's routinely been a screening test worldwide to detect someone with chest pain coming with we can send home or not.
And similarly, people like survivors who took endocrine therapy and those who didn't take endocrine therapy, both the groups had coronary calcium.
It's actually a sign of atherosclerosis basically.
Thank you so much. Thank you so much.